just let me know when to start.
I think we can start.
I think we can start.
Yeah? Okay. All right. So we talked about the oculomotor exam last time, and I told you we'll save the positional stuff for this time. So this time we'll talk about benign paroxysmal positional vertigo, or BPPV, which is the most common peripheral vestibular disorder. Basically, this is the condition where debris or otoconia, these little buggers, they're calcium carbonate crystals, they get displaced from the utricle. So they're located either in the utricle or the saccule, but they usually get displaced from the utricle because the utricle is what's connected to the 3 semicircular canals. They get displaced, and they can get displaced either in the canal or in the cupula, which is this bulge here. And that's where the name canalithiasis or the cupulolithiasis comes from. So I talked about how with canalithiasis you can get symptoms that last for a few seconds. With cupulolithiasis, the symptoms of vertigo when you do Dix-Hall pike or anything like that, or the symptom of vertigo can last for minutes. That's because when it's in the cupula is actually sticky, so the crystals have actually attached to the cupula, so they feel this symptom of the room spinning for a longer time, versus when it's in the canal, once their head stops moving and the endolymph inside the canal has stopped moving, they feel relief from the symptoms. So BPPV occurs spontaneously. It spells a vertigo, usually lasts less than 60 seconds, and that's canalithiasis. Common after head trauma. It's common after inner ear infection. So you can have vestibular neuritis and BPPV at the same time, because you can have, it's common with something like neuritis. It's can be seen with ischemia in the distribution of anterior vestibular artery. The most common cases affect the posterior canal more than the horizontal canal, more than the anterior canal. So it affects this canal more often than this canal, and then this one is the least common canal that gets affected. And the symptoms of vertigo are evoked by positional changes of the head. Contraindications or precautions are cervical spine concerns, so C-spine surgery, recent cervical trauma, neck pain, C-spine instability, cervical radiculopathy if the patient has low back pain or dysfunction, vertebrovascular artery insufficiency or obesity. So there's tests you can do to if, say, a patient has low back pain, instead of doing Dix-Hall pike, you can do something else. If they have neck problems, instead of extending their neck, you can do something else. Just a side note, use of meclizine or any other vestibular suppressants can suppress nystagmus during the positional testing. And also, if they're not wearing Frenzels, because it is a peripheral vestibular issue, they can fixate on something and you might not see the nystagmus. But usually we see them so acutely, we usually can see it as long as they're not on meclizine. But Frenzels really do help. So I brought them here so you guys can see them. They're $500, so if you guys, but if you're gonna play, be careful. And you can turn the light on. They look over here. Yeah, so you can see her eyes. So it actually magnifies the eyes for us.
Actually, look here.
Yeah. So we can see the nystagmus much better with this, because it really does magnify the eyes much better for. And then the patient doesn't.
See, Maria, turn this side.
Mm-hmm.
Turn this side.
Mm-hmm. Oh my God! Yes, yeah, it magnifies.
And the patient.
Yeah.
Yeah. And the patient can't fixate, so you're still seeing the nystagmus without the patient fixating on anything.
That is great.
We can probably do that on our iPhones, right? We're looking for nystagmus, like blow it up.
We can see your eyes now, Steven.
Wait.
My eyes just look normal now, right?
Steve, look here.
This can go to the.
I have to take a shot for
You're
break.
welcome. And then if you leave those on, Steve,
Uh-huh.
and with the lights off, if you can pull the black part up. So hold on.
I don't know what
He
you're
looks,
talking
he looks like a
This
scientist.
flips up,
Oh.
so I can still do the
Oh.
oculomotor exam
Ah.
without him fixating. Yeah,
Ah.
I just have to make sure the lights are off. Otherwise, it like
I don't see
messes up the mechanism.
Because she turned off the lights.
Oh.
Steven, you give for your mountain bike.
Yeah.
Everyone will run off and you'll win.
I don't think you will see Vertigo.
Alright. So it took me a few years to
I sent the
get these
pictures
glasses approved. Like 4 years.
Wow.
But, yeah,
Oh.
because they had to fit it in the budget and whatnot. But
Yeah.
finally got them. I was
Budget,
very
yes.
excited.
Yeah.
Anyway, so having these helps because then they can't fixate, and it magnifies the eyes so that you can actually see the nystagmus much better. Alright, so usually when I do testing for BPPV, I do the supine roll test first. This is to assess for the horizontal canal. So that's the second most likely canal to be involved. So posterior canal is the most likely, then horizontal canal. The reason I do this one first is because the Dix-Hall pike, if you do it, it's usually positive, but you can go right into the treatment. And also, patients get so exhausted from the Dix-Hall pike that they don't want to do this test. And if the Dix-Hall pike is negative and then they don't want to do this test, now you're unable to complete your exam. So this one's pretty easy. So basically you have the patient in supine with head in 20 degrees of flexion. What you want to remember is this little triangle is your tragus. To the corner of your eye, you want to have it perpendicular to the floor. So whether you flex the neck or have the patient in reverse Trendelenburg, in the bed in reverse Trendelenburg, you just want this angle to be perpendicular to the floor.
Okay.
That way the horizontal canal is in a horizontal plane. Then you quickly turn the patient's head to one side 90 degrees and you hold the position for 60 seconds. And you repeat to the other side. When you're holding for the 60 seconds, you're observing for nystagmus and symptoms and you're looking for if it's going geotropic or apogeotropic. Geotropic is going towards the earth, apogeotropic is going away from the earth. And, alright, Steve, you're gonna have to help me. This one.
Yeah.
So just.
The supine roll test assesses the horizontal semicircular canal for the presence of displaced otoconia that is causing vertigo. To begin, the patient lies in supine with her head in midline and pitched up 30 degrees.
It's 20-30 degrees.
Maintaining this head position, the patient's head is turned to either side. In this position, the examiner will be looking for horizontal beating nystagmus. This is also performed on the opposite side. Depending on the direction and duration of the beating, various conclusions can be arrived at. Beating towards the ground is known as geotropic nystagmus and may be indicative of canalithiasis of the horizontal canal. Whereas beating away from the ground is known as apogeotropic nystagmus and may be more indicative of cupulolithiasis.
gonna X this one out.
Can I ask a question?
Yeah.
So like if it beats either side when you're looking down, like it's geotropic, but does it tell you the side? Like
It's horizontal canal.
But it
Which
doesn't
side?
tell you which
Left or right?
right or
side.
left?
Oh, so I'm going to go into
Okay.
that. Okay.
Okay.
So, so you're going to do both sides no matter what. So even if you do it on the right side and you see geotropic nystagmus, you're still going to do it on the other side. So let me go, just so you're looking for apogeotropic or geotropic. And you're looking with geotropic nystagmus, there's usually a latency and it extinguishes. With apogeotropic, there's usually no latency and it's persistent. With geotropic nystagmus, the side with the stronger nystagmus is the side that's the involved side. Okay? So if I have them roll this way and this side has a stronger nystagmus, the right ear is the involved side. With apogeotropic nystagmus, so if I have them roll this way and this side is not as strong as this side, then this side is the involved side. Because it's the side that's the weaker side.
Okay.
Okay? Sometimes so I recently had a patient where I couldn't tell based on the nystagmus, and then sometimes you can ask the patient, which side are you feeling more symptomatic on? And the patient can't even tell. I can't tell. Then you can do what's called the bow and lean test. For geotropic nystagmus, when you do bow, and I'll show you how to do bow, nystagmus beats towards the involved side. And with lean, the nystagmus beats away from the involved side. So when you bow, you're basically having the patient lean forward. And if the nystagmus is beating to the right, that's my involved side. Lean is this way. And if I have them lean and the nystagmus is beating this way, this is my involved side because it's beating
Okay.
away from the involved side. Okay? For apogeotropic, it's the opposite. So if the nystagmus is beating, when I have them do the roll test and the nystagmus is beating away from the earth, I can have them bow, and if the nystagmus is beating to the right, I know it's the left ear that's involved.
Okay.
Okay? So this is just picture of bow and lean. Alright. So like I said, I always do the horizontal test first because it's a lot easier to do. They're doing it in supine, and in the video I showed, they did it a lot slower. You want to do it a little faster because you want those crystals to actually move, because the endolymph is gelatinous. If you're going to do it slow, you're not going to get the crystals moving, and you're not going to get the kinocilia and the stereocilia to move, so you might not see the nystagmus. So you want to do it a little brisk. Okay? Dix halt pike is to assess the anterior and posterior canal. So you do, whether you're assessing for anterior or posterior canal, you're going to do Dix halt pike. So what you're going to do, you're going to have the patient's head turned 45 degrees to the tested side. So with this patient, they're testing her right side. And you assist the patient in moving quickly from long sitting to supine while bringing the head into 30 degrees of extension off the bed. And hold the position for 60 seconds. Now, if you don't have a stretcher or anything where you can bring the patient's head off the bed, what I tend to do is in the patient's bed, I put the pillow in the thoracic area. So now you have extension here instead of putting the pillow here. The other thing you can do is move the bed in Trendelenburg. So that is good for somebody who can't extend their neck. So you're just putting the patient fully, the whole body's going flat, and the patient doesn't need to extend their neck. You don't need to have the patient extend their neck. You just need the position of the posterior canal and the anterior canal in that particular plane. So you can put the bed in Trendelenburg and still get the test done. All right? And you're going to hold the position for 60 seconds. You're looking for onset direction and duration. So is there a latency? What's the direction of the nystagmus? Is it upbeating and to the right? Is it upbeating and to the left? And how long is the nystagmus lasting? And I always ask the patient to keep their eyes open. Sometimes I have to pry their eyes open because the patient's not going to want to keep their eyes open. And you repeat the test on the other side. So you bring the patient up. And sometimes when you bring the patient up, they're going to feel the dizziness because you'll see the nystagmus, and it's usually beating to the opposite side. Let them take a 30-second break before you do the other side. Okay? And here's the video. And the sensitivity of this test is 79%, and the specificity is 75%.
Alright, you can close this one.
This one?
Yeah.
All right.
Halt pike maneuver is used to diagnose benign paroxysmal positional vertigo, or BPPV. Indications include vertigo-like symptoms, dizziness, or balance deficits. Contraindications include vertebral artery insufficiency. Position the patient in long sitting so their head will be at the edge of the table when they lie back. Rotate their neck 45 degrees toward the side you are testing. Support the patient's head and neck and instruct the patient to lie back as quickly as possible while keeping his or her eyes open. Maintain the patient's neck rotation and bring the neck into extension as the patient lies back. Watch the patient's eyes for nystagmus. The most common direction of nystagmus will be upbeating or torsional nystagmus, indicating posterior semicircular canal involvement.
Can we close it up?
Yeah, go ahead.
All right. So, if the patient can't tolerate the Dix-Hall pike test, say they have back issues, or they're obese and you can't physically do this test, you can do the Sideline test. Oh, before I go to Sideline test, because we have the hospital bed, I do the test from the front, and what I'll do, I'm going to use you. So I will do it from the front, and I actually have the patient hold on to me. So I'll have the patient hold on to me, so you can hold on with both arms here, because that actually makes them feel more secure, because the room is spinning. So having them hold on to me as I'm doing it, and then I'll go and I'll say you can hold on to me, and I'm going to bring you back, and it actually makes them feel more secure as I'm doing it. And this way I can look at their eyes too while I'm in the front. Just watch proper body mechanics. So I raise the bed fully up and then do it. So Sideline test, what you're doing is sitting the patient on the side of the bed, head 45 degrees to one side, and you quickly lie the patient down to the opposite side, and you're testing the side you're laying the patient down on. So you're with this patient, you're testing the right side. Okay? So you're testing the right ear. Okay? And you're observing the nystagmus and the symptoms.
This is also for posterior?
This is
semicircular
posterior and anterior. Yep.
canal? Okay.
So you can do Sideline test, and this actually has 90% sensitivity and 75% specificity, so it actually has more sensitivity than Dix-Hall pike. We just do the Dix-Hall pike more often because the treatment, as you'll see, goes right into
Okay,
it
please.
with Dix-Hall pike. That's why.
Sorry.
Okay.
She just showed up.
So this is the Sideline test.
The Sideline BPPV test is an alternative test to test for BPPV if the patient can't go from a long sitting position to supine. We're going to have the patient rotate their head 45 degrees to the left, and we're testing the right ear. On the count of 3, I want you to lie down as quickly as you can onto your side. Ready? 1, 2, 3.
Oh my god.
You have to do it fast.
Oh god.
Monitoring for any
They're gonna hit me after
that. Maintain this
Yeah,
for
we're too
approximately
weak.
a minute.
I'm super gentle when I do that.
Yeah, you have to do it fast. And same thing with Dix-Hall
Yeah,
pike.
when she sits up.
That's why most of the time it's negative.
Negative, exactly. I saw an ENT doctor do a Dix-Hall pike one time. I've never seen anybody do a Dix-Hall pike that slow. He's like,
I want you to lie down.
Maybe
One,
they,
two,
even if
three.
they didn't have a dislodgement in the first place, can this dislodge?
Yeah.
position for a minute. Again,
I
monitoring
haven't
for
seen it
any
happen,
nystagmus
but
or symptoms of vertigo. After approximately a minute, you're going to go ahead and sit up.
alright. So it has to be fast. Yeah.
It's like slamming
But
them
then
down.
they're so big on top that they're screaming and yelling.
And usually with the bigger ones, they do it a little. I mean, he went pretty fast. You're actually going to end up
You're
going a
supposed
little
to be doing
slower.
like
You
that.
rotate
but-
the head before turning them down?
Yes,
I
yeah.
always do
You
this
always
one.
rotate the head first, even for Dick's Hall Pike, because you're gonna do extension as they're going down,
Right.
and with this you're doing sidelining, so you're holding the patient as you're going onto
Do
the
we
side.
have them look like in a certain direction?
You're just looking looking at their eyes for this.
But we don't tell them to look down or up.
No,
or
because
straight.
you don't want them to fixate. Because if they fixate, you're not gonna see
They'll
the
lose the
nystagmus.
nystagmus.
That's why Frenzels are beneficial, because then you don't worry about it.
Can you
But
put the Francis and still do the Dix Hall?
yeah,
Yeah.
that's when you are supposed to do
Oh,
Dick's
yeah.
Hall Pike with the Frenzels, because you don't want them to fixate. So all positional testing should be done with Frenzels. But if you don't have it, then
Yeah, let's tell the
Try
ED
it.
to get one for each
For
pod.
each
yeah,
pod.
Yeah.
So you want to do it as even Dick's Hall Pike. You want to do it fast, because again, if you don't mobilize the endolymph, you're not going to mobilize the crystals, and you're not going to see the crystals moving or the nystagmus. Okay. So basically, the way you know if it's posterior canal or anterior canal, if it's upbeating, it's posterior canal. So if the nystagmus is upbeating and torsional, it's posterior. If it's downbeating, so the way you remember it is pup or Dan. Pup is posterior, Dan is downbeating. Okay.
Right.
So if it's upbeating and right torsional, it's the right ear that's involved. If it's upbeating and left torsional, it's left ear that's involved. If it's downbeating and right torsional, it's right anterior. And if it's downbeating and left torsional, it's left anterior. You're also going to look at the timing of the nystagmus. So if the nystagmus ceases before 60 seconds, then it's canalithiasis. The reason you want to know that is because it affects treatment. If it lasts longer than 60 seconds, it's cupulolithiasis. So it really affects how you're going to treat the patient. Involved canal for horizontal canal, this is just a repetition. Geotropic would be canalithiasis. Apogeotropic is cupulolithiasis. With geotropic nystagmus, the more intense side is the affected side. With apogeotropic, the less intense side is the affected side. And just red flags that you guys already know if you see any of these neurological signs. Except we talked about this just again, spontaneous nystagmus in room light after 2 weeks, because spontaneous nystagmus within the first week is normal even with peripheral disorders. Alright, so this is the treatment. I'm just going to go over treatment for the most common type of BPPV because it'll get really confusing if I go over all of it. So, canalithiasis is the most common, whether it's right ear or left ear. So this is treatment for the left ear, left posterior canal. Left posterior canal canalithiasis. So you basically start out in the Dix Hall Pike position. You actually do left Dix Hall Pike. That's the first thing you're gonna do. Okay? And then you're going to stay there until the nystagmus ceases, plus, so if the nystagmus lasts for 15 seconds, you stay there for another 15 seconds, and then you quickly turn their head to the other side, keeping the neck extension. So see how her neck is extended here, and then they turned her head here, and they kept the neck extension.
So that's why she has the pillow,
Pillow,
like
thoracic.
here.
Thoracic,
so she can be-
yeah.
okay.
Yeah. So this is something, it's kind of what we would do in a hospital bed.
That's what we could have done for the morbidly obese patient.
Yeah. So you would, if it lasted for 15 seconds, we would do 30 seconds here and then 30 seconds here in this position, And then the next thing you would do is lay the patient in sideline, holding the patient's head in that same position.
Mm-hmm.
But as they come to sideline, you want to get a chin tuck. Okay, and in this position, the patient will likely complain of more vertigo. Because this position, the crystals are actually kind of dumping, so they actually feel the room spinning. So they usually feel room spinning most here and in this position. Again, you're going to stay here for the amount of nystagmus time plus that extra time. And then you can have the patient drop their legs off the bed and sit up. I always hold their head in position and support their back, because as they come up, they can get really dizzy and they might lose their balance backwards. So as they come up, hold their head, and then once they come to sitting, I bring their head to midline.
Okay.
Okay?
So, but the key is then, so when we do the Dick's whole bike, like being super fast, and like when we turn the head also has to be like fast, like everything
Has to be.
yeah, we're super gentle.
Yeah, because you have to be fast if you're gonna. If you think about the endolymph, it's gelatinous. If you're not moving it fast, you're not actually moving
Right.
the crystals through the canal back into the utricle. So you have to be fast. So this is just more directions. With the patient's 45 degrees to the affected side, assist patient moving quickly from long sitting to supine while bringing head into extension 20 to 30 degrees. Stay in the position till the nystagmus stops or twice the amount of the initial nystagmus. Rotate 45 degrees to the other side while maintaining the extension. Stay in the position till the nystagmus stops or twice the amount of the initial nystagmus. Roll to the unaffected side, maintaining the head in the last position and adding a chin tuck. So don't forget about the chin tuck. That's really important. Stay in the position till the nystagmus stops, same amount of time as I mentioned, and then slowly assist the patient into sitting and then bring the head into neutral. Okay?
So are they still extended with the chin tuck, or they're
No, because when so you
it's afterwards, right?
yeah, as they're coming into that position, you're holding and then bringing their head into. So if they're like this, and then this. Okay?
Yeah.
All right. You want to do the video? All right. So
Today I'm demonstrating the canal repositioning technique, which is a common treatment technique for benign paroxysmal positional vertigo, or BPPV. First, you quickly lower the patient to the table, bringing their head down into extension and rotate it to the right. You watch their eyes for rapid eye movements or nystagmus. You'll maintain this position for about a minute or until the vertigo goes away. And then in the next step, you will rotate their head quickly to the left while maintaining neck extension. Again, watching their eyes for that nystagmus. You'll stay in this position for approximately a minute as well, or until the nystagmus resolves. And the next step, they will rotate the patient onto the left side, keeping the head rotated and then slightly drop them into flexion.
you see the chin tuck.
Again, maintain this position for approximately 1 minute, and then you'll instruct the patient to sit up at the edge of the bed, help them get up, and again, watch their eyes for that nystagmus, and make sure they're safe to sit independently.
She obviously does not have BPPV because they don't sit up that fast.
What causes that nystagmus? Is it the sensations that the hair cells feel on the other side because of the cupulas, or the movement of the fluid starts the whole like eye movements?
What causes it? It's like the imbalance from
The
signals,
Yeah,
yeah.
the eighth nerve. Yeah.
Yeah.
It's just
All right, so this is the other maneuver you can do for somebody who can't tolerate having their back going from long sitting to supine. So you can do the sideline test and go into, it's called Ciment maneuver or Liberatore maneuver. When you see this maneuver, you'll see it, you're gonna be like, oh my god. I've actually had to do this maneuver for somebody who had CT surgery and had BPPV after CT surgery because I couldn't do Dick's halt pike because of sternal precautions. So, and he actually felt great after doing this maneuver. So basically, you're going. Just remember so the previous maneuver you can do for anterior or posterior canal canalithiasis. For Ciment maneuver, you can't do this same head position for anterior and posterior canalithiasis. The head position changes. So, with posterior canal, the head is facing to the opposite side as they're laying down first, and then the head is facing down as you're laying them down on the other side. With anterior canal, the head starts out facing down and then goes facing up. So, but like I said, this is the most common, posterior canal is the most common canal that's involved.
So how do we know if it's anterior or posterior? We do posterior first. If it doesn't work, do the anterior?
No, you remember you've done the Dix Hall pike
Mm-hmm.
to figure out if it's up beating or down beating.
Oh, right, pop or yeah, done.
Pop and Dan,
Right.
not Tom. Where'd you bring Tom in?
No, I said pop and back.
Oh, okay. I thought you said Tom. I'm like, who's Tom? All right, all right.
Yeah, it's a bit. It's like we have to like. Okay, one more time.
That's all right.
Say
that's
it one
all
more
right.
time. Because
Yeah. So once you figured out which, and the way you figure out where the head position would be is if posterior canal is in this plane back here. So if you bring the head like this, now it's in the horizontal plane, and now you can lay them here, right? Anterior canal is in this plane, so you lay them this way, and you're starting out with the head down. I know I'm telling you, I took over.
confusing.
Review this.
That's
Super
why I'm
confusing.
only going over one treatment, because otherwise you guys would have been so confused. That's why I'm just doing the main treatment, and the first treatment I showed you is probably you're gonna be the easiest. I've only had to use this treatment once, and that's because it was a CT surgery patient. Oh, what's going on?
just click.
Just click
whatever.
anywhere,
I did.
Click with that.
Oh.
Yeah.
So, Ciment maneuver or Liberatore maneuver, rotate the head 45 degrees to the uninvolved side, quickly lie on the involved side while keeping the head rotated 45 degrees, looking up for 2 minutes, quickly move to lying on the opposite side while maintaining the head in the same position, looking down for 2 minutes. And you'll see why I hardly ever do this.
It's not the same guy.
Oh,
Give it like-
it's rough even when we were practicing on each other when I took this certification course.
Oh man. I feel like you caused dizziness with this.
I felt dizzy, but it wasn't vertigo.
And turn their head 45 degrees to the unaffected side. Place one hand behind their neck, your other hand on their cheek, and help them lie down on their affected side. Keep them there for 2 minutes.
And she went a lot slower than you're supposed to. You're supposed to go.
On the unaffected side. Keep them there for 2 minutes and help them to sit up.
So the head goes away of the side of the lesion, but you put them down to the side of the lesion.
Yes.
Okay,
Yeah.
so like this.
Yeah. Yeah.
And then,
Yeah.
for how long? You leave it there for 2
2
minutes,
minutes,
and then
yeah.
you set them up. So
Yeah.
2 and 2.
Yes. Yeah. So these are the basic treatments. So for canalithiasis, you can do the canalith repositioning maneuver or the liberatory maneuver. I don't know what that is.
Here, I can just close it or whatever.
Okay, try these treatments or wait for you.
So if we have a few minutes, we can try it.
No, she was saying,
We just
should
say,
we
like,
do
on
it
our
or wait for
patients.
vestibular therapy?
It's up to you.
Uh-huh.
Shri wanted me to go over it with you guys, so here I
this is
am.
very helpful.
He's like,
I like
go
it.
over all the treatments. I'm like, I am not going over all the treatments because it will be way too overwhelming. So
You should do this lecture also for ED
I know.
and
Oh, yeah.
medicine. I think we
That's
all
so-
would benefit from
My
this.
plan is to get involved with the ED so they can call us for vestibular patients.
first before
Soon.
calling the neuroconsult.
CTA.
Right, because then they can avoid ordering a lot of the tests and things.
CT.
But
Tons of MRI, tons of CTA.
what I'm trying to, do you remember the standing algorithm I went over with you guys
Yeah.
last time? So I'm trying to get all the PTs competencied on all the tests. So, because if I'm the only one who can do all the tests, I would have to be here all the time.
Yeah.
So I want to make sure so they're competencied on the first two columns. They need to do the positional testing, which is this year. And once that's done, I want to get involved in the ED. So that's my long-term plan. But anyway, so for canalithiasis, you do CRM or you can do liberatory maneuver. For cupulolithiasis, you can only do the liberatory maneuver. For horizontal canalithiasis, so if you do find a roll test that's positive, give me a call. You do barbecue roll, which I don't do because that involves literally having the patient go get on their belly. I don't do that. Epiani maneuver is a lot easier for the patient, so I usually do that. For cupulolithiasis, you can do Kasani. There's also Gufani or bump and dump. So there's a lot of Italians involved in this. So you can do a lot of different tests or treatments. So in terms of communication with the acute care team, medicine, whatever, you just want to let them know that the vestibular eval really does help reduce the cost for the hospital stay. It helps decrease the length of stay. It defers ordering tests that may not be needed, such as stress tests, CAT scans, because if you do find a vestibular cause for it, there might not be a need for it. Specific vestibular findings and treatment are underdiagnosed in ED, they found, and they've seen that one study found it, dizziness patients cost $4 billion a year. So, and there's a overutilizations of CAT scans and vertigo meds for patients with BPPV, and the cost is about $2,000 per patient. So you can see how this can help save the hospital so much money if we get involved sooner with these patients.
Yeah.
And
Look at the ears.
what's that? Yeah.
At least look at the ear. I had one lady that did a CTA and everything, and she's still dizzy. It's like full of airwax still here.
So I mean, just getting involved early on, it might be helpful. And then corticosteroids are underused for vestibular neuritis and labyrinthitis, and which can delay their treatment. So if you find that their head impulse test is positive or gaze evoked nystagmus is positive, start them on a corticosteroid because it's actually shown to help speed up their recovery. The recovery endpoint is the same whether you start the corticosteroid or not, but when they're in a hospital, we want to get them out.
Yeah.
So they're going to start feeling better faster. So that's our way out of getting them out. Also, if they start on meclizine, a lot of times medicine doctors, ER doctors, give them a standing dose of meclizine. Meclizine should only be prescribed for the first 3 days for a peripheral disorder because it's a vestibular suppressant and it's going to delay vestibular adaptation. So it's a lot of education on our part to tell them, okay guys, only for 3 days because it's peripheral. If it's central, go ahead, give them the meclizine, it's going to make them feel better. But if it's peripheral, just for the first 3 days. Also referral to outpatient vestibular rehab or inpatient rehab, depending on what they need. But it's been shown that early rehab decreases their degree of handicap and it improves their quality of life. And there might be a degree of unfamiliarity with the ED docs and the medicine docs in terms of vestibular disorders. So, like you guys said, it might just be an education.
Flipped. I think the first thing they do is consult neurology, and then they do the rest of it.
Yeah, and I think it might be important for them to just consult PT or, get...
And we had a patient and we had to tell them, just get PT vestibular therapy to help with that.
Well, thank you guys. I'm glad you guys said something. So, and then we can look into referring to other specialties such as neuro, ENT, psych, occupational therapy, or cardiology. And these are my references. You guys have questions?
Oh, that was really good.
No, it was great.
Yeah.
I loved it.
Oh, thank you, thank you.
Like, still gonna get confused in the eating.
What's that?
Can we call you like Jigisha? Which one was the maneuver for the horizontal?